sensitive again. And we actually got a US patent for that. And the patent has expired and we haven't made a dime on it. But it was an interesting observation. So it's interesting that, that question came up because, for example, radiation therapy and immunotherapy, there's been some reports in the New England Journal of Medicine where patients, had a certain immunotherapy, responded a certain amount, got radiation, then had a huge response to the immunotherapy.
Right. Yeah. So, and I think that's a great point. So it's not just chemotherapy. So it actually is radiation therapy too. It's some very specific kinds of radiation therapy, and there are trials that are actually looking at that now, like using. Somebody asked about stereotactic radiosurgery. So like looking at gamma knife and stereotactic radiosurgery flanked by immunotherapy, like it clearly in kidney cancer patients changes the effectiveness of IL-2. Like it looks like it almost doubles the response rate. And there's a bigger trial trying to prove that now. And we think the same thing goes on in melanoma, but not quite to the same degree. So there's lots of reasons to, like I said, that last slide I showed you, like we're gonna spend the next 2 decades trying to figure out what the right sequence of some of these things are. And my bet is what happens is that we actually get too many drugs. We get so many drugs so fast that some of these things aren't going to get answered, or at least not going to get answered in a way where we can move forward. But there's a lot of questions out there. We don't know nearly as much as we need to answer what's going on.